Well, hello, everyone. My name is Leslie McGill, and I am the President and CEO of MedicAlert Foundation Canada. I have to sincerely apologize. It never fails when you're about to do something. Technology gets in the way, so we had a little bit of a late start. But I am glad you are here, and I am very excited to welcome our guest today for Health Hour Live. Dr. Tara Kiran is the Fidani Chair in Improvement and Innovation at the University of Toronto and the Vice Chair of Quality and Innovation at the Department of Family and Community Medicine. She is a family practice a physician out of St. Michael's Hospital here in Toronto. And one of the things that Dr. Kiran investigates is how changes in our healthcare system impact the most vulnerable in our society. And her research and practice in that work that she does, she develops and tests solutions to make healthcare more inclusive and more effective. And I couldn't think of a better topic or a better introduction to today's event than to really talk about those who are vulnerable and some of the challenges we're facing here. So welcome, Dr. Kiran, Tara, if I may, to Health Hour Live.
Thanks, Leslie. It's great to be here, and thanks everyone for joining. I'm looking forward to this dialogue.
So Tara, if you would, can you start by telling us a little bit about the very extensive project that you and your colleagues worked on called OurCare? What was the actual impetus for this research study?
Yeah, so I've been a family doctor now for over 20 years since I graduated from medical school in 2002, and I began doing research to try and improve the system in 2008. And since that time, I've actually been part of a lot of discussions of like, how can we do better as a system and put forward recommendations? And usually what I've noted, when I'm part of these discussions is there's people like myself around the table, people who are family doctors or clinicians, maybe there's some researchers or healthcare policy wonks, people in government. But usually there's a really important voice that's missing, the voice of patients in the public. And that was really the impetus for this project. I've been now doing research for a while, as I mentioned, and over the last few years, I've really come to understand the importance of centering the work we do, whether it be work in the clinic or work at a health system level, centering that work on the needs, priorities, and values of patients in the public. And anytime I work with patients in the public, I'm also always struck by how much some of our own assumptions are challenged and how they help us to see things clearly. And what I do know also is that sometimes what can hold us up in terms of healthcare reform is that we can become kind of really focused in our own kind of bubbles, our silos of what we think is important. And my hope had been that by bringing the patient and the public voice to the forefront, we'd be able to find a common ground and really all be able to align in terms of what we know should be our North Star, which is what patients in the public want to see happen in our healthcare system.
So I'm dying to ask you and dive a little bit deeper into all of this. It's absolutely incredible. I mean, you and your colleagues surveyed 10,000 Canadians. That's not a small number to talk to. And what you were really looking for, I think, is really whether people had a family physician or a nurse practitioner, as many people do these days, and what matters the most to patients when it comes to primary care, sort of the gateway to the healthcare system. And so for the people on this call today, the big question, the one that we heard the most and saw the most from our own little research that we did here in terms of this was overwhelmingly people are asking, how do I find a family doctor? Why does it seem all of a sudden that this is an issue? Or is it been something that we've really known about for a long time, but suddenly it's popped up its head because of your study or some other factor in the environment? I'm very curious about that.
Yeah, so, unfortunately, it's actually been a problem for a long while. I mean, we've known that not everyone has access to primary care and that access has historically been uneven with people in lower income neighborhoods, and people who are new to Canada struggling more with accessing primary care. So this has been ongoing for years, and I think I've written op-eds and articles and done research about it for well over a decade. But unfortunately, the problem has actually gotten worse instead of better. And of course, part of the reason it's gotten worse is, so much in healthcare was strained as a result of the COVID-19 pandemic, and we haven't recovered, and things are different. The landscape is essentially different coming out of that, the intensity of that pandemic. And so, I think the problem has grown so big now, and it affects so many people, that it's really topical and front of mind. And I also think that my colleagues and I have really worked hard to make sure that this crisis is really well understood by people in government positions. So there's been, a concerted effort by us to make sure that it's not just about hallway medicine or emergency department, that people understand that primary care is the front door to the healthcare system. And in fact, it's been in crisis for a while. That's gotten worse, and it's part of the reason that other parts of the healthcare system aren't able to function either. So, why are we in where we are? It's a big question, but there are many different factors. So as I mentioned, the COVID pandemic, nudged some people closer to retirement for a variety of factors, sometimes health related, sometimes work-life balance related, sometimes related to finances, because it was hard to keep practices open during the pandemic when your income is based on people coming in to visit, and people weren't coming in to visit, understandably, because we didn't want them to, because we wanted them to stay safe at home. And then on top of that, what we know is that we've got a workforce that is actually nearing retirement in general. So a large proportion of our workforce is over 65, and some of them are choosing to work less or not to work at all, which is completely understandable. But unfortunately, we made a decision in the 1990s to curb medical school enrollment, and that's left us with fewer doctors per capita, and that's part of the strain that we're seeing now. And then family medicine is also like an unattractive specialty for many new graduates, and there's a number of reasons for that. So we see fewer people choosing family medicine, fewer people who choose family medicine actually deciding to train and actually do family medicine in open up a traditional family practice. Instead, they choose to use their degree in different ways. Why is that? So a whole variety of factors, everything from amount family medicine pays to kind of the way that family practice traditionally operates. It's very much a small business model, and many of our new grads aren't interested in the business side of things. They want to just graduate and practice medicine. There's very little supports in terms of, other team members, or let's say if you want to go on vacation or on a parental leave, there's very little support to be able to do that. And so it doesn't offer the work-life flexibility that some other types of work do, for example, working in a hospitalist environment or an emergency room. So what we see is, fewer and fewer people choosing to do family practice. So those are just some of the reasons behind why we are where we are. There are others because it is a complex issue. But all this to say is that our research really has confirmed that there are more than 1 in 5 people right now who don't have a family doctor or nurse practitioner, which translates to the general population of more than 6.5 million adults across the country, which is just far too many.
So it is absolutely unacceptable from my perspective, and I'm sure everybody on this call's perspective, that that's the case. If we could delve maybe a little bit deeper into some of the decisions and you and I haven't had a chance to talk about this directly, but I'm sure your research has sort of uncovered a little bit, or at least your conversations with government. And the decision that was made in the 90s to pare back medical school enrollment, could we not, or could government not have seen what was on the horizon for this country in terms of the aging population and the challenges that come with a population that's aging? It's not that long ago, quite frankly, and it seems to be that would have been an obvious perspective. But what was the impetus, if you can recall, around the decision in the 90s, and how is that really hurting us now? And why haven't there've been different policies to change that if people began to maybe recognize a decade ago that this indeed was going to be something that was going to be a challenge.
Yeah, so the decision in the 1990s really amounted to one that governments thought would help to save money. So if you have fewer doctors, there are fewer doctors to pay. And so it costs governments less. So I think it's pretty simple as that, as it's a way of cost containment. There was a very comprehensive report that put forward a number of recommendations related to health, human resource planning, and healthcare. And, cutting the physician workforce was one of the recommendations, but there were other ones. And I think the other ones were, more complicated, maybe required different resourcing. And unfortunately, the government, it seems, chose to pick up one of the recommendations, which was cutting medical school enrollment, but not some of the other ones, like increasing, for example, other health professional contributions within the healthcare workforce. So if we'd had a situation where there were fewer doctors, but let's say more nurses and nurse practitioners, maybe we wouldn't be in this crisis. But at the same, but those things like didn't happen. And so I do think governments did recognize that, this was, that they needed to correct course, and they did do that several years in. However, what happened is that there was this period of time where we weren't graduating the number of physicians we needed to. And when you look at the graphs of, how old doctors are, and you can really see that there's this period of time where there were fewer doctors graduating, and that's part of the reason why we just don't have as big a workforce as we need to. And so, yeah, I think they're trying to do a lot of catch up now. You hear announcements of new medical schools being opened up. We've heard those announcements, for example, here in Ontario, and I think those are good things. We do need more doctors to be trained, and some of those medical schools are focused specifically on family doctors. Of course, it's not just about training the doctors. We need to ensure, and it's not just about medical school enrollment. We need to ensure that the full breadth of training is funded, so that there are community family doctors to help to train the next generation, and that those family doctors are compensated for that. It's not just a medical school seat. But then we also have to make sure that, those family medicine is an attractive profession for those people who are graduating from medical school. And I think that's where we have some work to do. So that means that family medicine has to, feel like a respected profession. And right now, I'd say, the narrative, even within the medical profession, and certainly sometimes in the public discourse and in policymaker discourses, it seems like it's a lesser than specialty, when in fact, actually, complexity and generalism has become harder and harder, and we rely more and more on it as people have many, many conditions, and there's a complexity to the way people are, both medically and socially, that only really generalism can account for. And so we don't often get the respect that we need, and some of that manifestation of respect, honestly, is money. So why would someone choose to be a family doctor if they can make more money as a specialist? I think everybody can kind of understand that kind of logic, because people do make decisions based on their own interests, which is, I think, just very understandable. So we need to align things so that family medicine is an attractive profession moving forward.
So I think that there are real challenges. It's not as simple on the surface as some people might believe it is. If we just do one thing, there's a lot of sort of ancillary supports and investments that need to be made. And the study actually notes that in other countries where there's been an investment in primary care, people tend to be healthier. And that's fascinating data, interesting data. We do okay in this country, but what would an investment in primary care in Canada do in terms of making sure that people are healthier? And why, or is that becoming the discourse in Canada now? Or is that something you're aiming to actually become the discourse? I know the answer to that question, but maybe you can elaborate a little bit around that. It's a multi-parted question, I understand.
Yeah, well, the late Barbara Starfield really has done the majority of research in this area, that when she looked at healthcare systems across the world, what she found is that healthcare systems that had stronger primary care had better outcomes for their population. So their populations were healthier overall. they actually had less differences in health outcomes between different population groups. So they had better equity, and they actually also had lower costs. And so this body of knowledge has been out there for well over 2 decades. And I think, unfortunately, it's not so well appreciated by policymakers always. And so we're trying to draw attention to this long-standing evidence that links primary care to better system outcomes. The other research that we know is very strong out there really relates to this idea of, the benefits of an ongoing relationship with one family doctor. So there's a lot of research out there that shows that a continuous relationship, so where you're seeing the same person over and over again, actually, results in you getting more of the tests that you need, including preventive care. It means better health outcomes for yourself. It means less use of other parts of the healthcare system. It means less costs for the healthcare system. And it even translates to like lower mortality, so fewer deaths among people as well. So a really strong body of evidence, again, around just this idea of a longitudinal or ongoing relationship with one person who you see again and again and again. And so if we invest in primary care, I think what we would see in Canada is a strengthening of health. People would be healthier, people would be living longer, and I think it would cost us less, because what we're doing is we're investing upstream as opposed to downstream. So anytime we put in our dollars in a way that actually prevents problems from happening and prevents people from seeking care that's more costly, because we're able to manage it at a time where the management is easier, things are caught earlier, the treatments might be more straightforward. Anytime we invest in that kind of prevention, we are saving money and we are saving lives.
So, well, you and your colleagues and the entire team here at MedicAlert believes in that philosophy of prevention upstream. We really don't want to end up in a hospital. That's when people are the sickest of the sickest, and that's really not necessary. At least from my perspective, having been in the sector for as long as I have. I won't say quite how long I have, but that's been a conversation that's been ongoing. But our system has been built for illness, not wellness, and I think that's one of the shifts that primary care can help with, in my opinion. But I want to reflect on something that you said. Actually, as I was thinking and preparing for this call today, I thought about how many physicians have I had, primary care physicians. I'm lucky enough to have a primary care physician today. And over the course of my life, I've had 5. I don't know whether that's average or not, but that consistency, especially in my university days and after that, I had a 28-year relationship with my family doctor, and it was amazing because she knew me. She understood my context. There wasn't a lot of dialogue along the way because she understood what I was there for. There wasn't a lot of preparatory work, and certainly those predate the days of electronic medical records. It was all in the written handwritten charts, etc. But there's a phenomenon or a more recent phenomenon around team-based care. And for many of the people on this call, and me included, because I'm not in a practice right now where it is team-based, but that's a different concept than perhaps many people are used to. So what are the benefits of team-based care versus a single practitioner?
Yeah, such a good question. And so one thing I will just say at the outset is one of the tricks to trying to get team-based care right is for us to continue to have the benefits of a relationship with one or more people while leveraging the expertise of more. So there are many benefits of team-based care. I think, I will say that I actually work in a wonderful team-based model. I work at the Health Center 80 Bond, which is part of the St. Michael's Hospital Family Health Team. I'm lucky to work with like nurses, nurse practitioners, a pharmacist, social worker, income security health promoter. We even have a chiropodist and a physiotherapist as part of our team. So I'm very, very fortunate, and I've come to really rely on these other team members in order to be able to best serve my patients. And so, as a family doctor, for example, I think, how would I collaborate with my other team members? Well, we know that, patients are more and more complicated and complex, and that the world is actually more complex, and that there's more medicine actually out there as well. There's more social types of interventions in care as well. And as a single individual, it's hard for me to keep on top of everything, given the complexity of all of the various things that are happening. And so, as an example, since I graduated, there are many new treatments for diabetes. So let's take diabetes as an example. Like, there are many new treatments for diabetes that I didn't learn about in medical school. And in order to best integrate them into my practice, I actually really rely on our pharmacists. And many people with diabetes, though, they also have many other health conditions. And so, our pharmacist is able to help advise me not just on what medications might be best, in general for managing diabetes, but for the specific person, given the other medications they're on, what are the medications we should consider? What are the potential interactions? And even further, they are wonderful at being able to counsel patients, to tell them about the different choices out there, the pros and cons, and help have a shared decision-making process around that, and then support them, for example, to actually use that medication. Because as you know, for example, some of the new medications are injectables, something that patient may never have done before. And so you can imagine, just even in that one scenario, if I were going to do all of that for my patients, first of all, I would do it badly. Like, I wouldn't know all of the things that the pharmacist knew. But second of all, it would take me a lot of time to do all of the things that I mentioned. Instead, I can say, oh, you want to meet with our pharmacist? The pharmacist I work with, her name is Brenda. She's lovely. I can book you an appointment with her. The patient will sometimes talk to her on the phone or come in. And Brenda would be the one that is counseling the patients on the medications, and that following up even on that too. How's it going? Are you having any issues? That's just one example of the kind of thing that a team member or a pharmacist would be able to do. I think you can imagine that there are, many different patients. So about 30% of the work we do as family doctors is mental health and addictions. My social worker is completely invaluable from that perspective. They're able to meet with patients to help them navigate a very tricky social care environment. They're also able to meet, in our own practice, they run groups for people, for example, who have depression or anxiety. They can also provide sometimes limited one-on-one counseling, or, suggest where they might be able to get more supports. So those are just like a couple of examples. When it comes to our nurse, again, like a core part of my team, they are able to do a lot of the preventive type of care, independently from myself, and also some of the stable chronic disease management, a lot of the care coordination that's required. So I think what I'm describing, Leslie, is just that, when we work in a team, the team members can do a number of things. First of all, they bring other expertise that overall I think can help to improve patients' health care and outcomes. Secondly, they actually help to offload work from the family doctor or nurse practitioner, the most responsible clinician. And we hope that by having more teams, it actually means that the capacity of family doctors to see more patients grows. And I gave you some examples where I think that kind of can be illustrated. And then I think the other piece that I haven't got at is, there's also a lot of evidence that working in teams can be more fun, and it can actually bring more joy in work, because you can imagine if you have the burden for caring for really complex sick patients on your own, that can be really heavy. But when you have a team member there who you can talk that through together, you're trying to support the patients, not just you yourself, but with someone else who has different expertise, that can like all of a sudden go from feeling lonely to actually feeling like supported, and give you a different kind of energy that's needed to support patients and do the work that you want to do. So 3 reasons for teams: improved health outcomes, improved clinician work life, and the last one, that we need teams really to grow that capacity of family doctors to see more patients.
So that's a fascinating perspective, and I hadn't even given any thought to what work-life balance or team-based work was for the physician And those in the clinic, we kind of just go and have a one-to-one relationship most often. Whereas many of us who are not physicians are working, I mean, now COVID and remote work has changed that a little bit recently, and probably there's a little bit of empathy that we can have for physicians who have been fundamentally practicing as individuals for a really long time. And teamwork is fun.
Yeah, teamwork is fun.
It does bring joy, it brings purpose and all of those sorts of things. So it's not really what you're, from a very simplistic perspective, what you're saying is really, it's not a team of doctors, it's a team of healthcare professionals that really have and bring that an interdisciplinary perspective to the work. Not everyone has access.
Yeah, I think just to build on that, Leslie, I think it's actually, it's a really great point you raise right now, because I would say for me, it's about a team of doctors, and then layered on top of that is a team of other health professionals. Because in order for the other health professional part to, I think, work well, you do have to have a team of a group of doctors that are working well together. And so I do have that in my clinic. You know, for example, at our clinic, we have 12 other doctors that I work with. And as an example, if I'm not there, they might be able to they'll be able to cover my practice, and vice versa. We share after hours call, things like that. So I think we need to have that baseline of doctors working together, but then absolutely we need to have the other health professionals on top of that.
So it's more complex than I think people ever really realize. I'd like to switch gears maybe a little bit, Tara, and talk about patient rights. Rights to access care, rights to access their records. But for so many people, these things seem to be shrouded in some mystery. So what exactly are a person's rights these days? And what should people be questioning about that perhaps they haven't necessarily thought of questioning when it comes to their rights as a patient?
It's a really good question. One of the things we are fighting for is to make it a right that you have primary care. I think, unfortunately, the way it's structured right now, people in Canada have health insurance that would cover a visit with a physician, but there's no guaranteed access to a family doctor or primary care team or nurse practitioner. And so unfortunately, I don't think I can use the rights-based language to say that there's a right to primary care right now. But what I've been saying, and my colleague Jane Philpott, if you've read her book, Health for All, what she's saying is that we need to have actually legislation that makes primary care a guaranteed right, in the same way that, a public education is a right for our children when they move into a neighborhood, they're guaranteed access to a public school in the same way you should be guaranteed access to primary care. So that's not the way it is right now. And so just, what are the other rights that you do have? I mean, I would say, you have a right to be cared for when you go to the emergency department. I'd say that a family doctor can choose to close their practice because they have too many patients, but they're not supposed to be cherry picking which patients that they choose within their practice. And if you think that it's happening, that that there's cherry picking happening, that you're not being led into a practice because you're too complex, but other people are being led into the practice, it's important for you. You also do have a right to complain to the College of Physicians and Surgeons of Ontario, or the college in your own province. So every province has a College of Physicians and Surgeons that is part of the self-regulation for physicians. And if you have experienced any kind of mistreatment from a physician, or you think that your care has been biased, for example, and you haven't been accepted into a family practice because of bias, you have the right to complain. Some provinces, and then those complaints are taken very seriously, and there's an investigation launched. Some provinces actually have an ombudsman or ombudsperson. And I would say, again, you have a right to complain and register your complaint to the ombudsperson. Now, the scope of the ombudsperson varies, and sometimes primary care is not in that scope. But if again, you think that the system is failing you in some way, including even not having primary care, I'd say, yeah, you should contact the ombudsperson. I think that everybody in Canada should have a right to their health record. Now, realistically, do you have access to your own health record is a whole other thing. And that's something that we heard very clearly from patients in the public that they wanted to have. But if you should be able to request your health record from anybody who has it, and they should be able to give it to you. Now, unfortunately, in some cases, healthcare professionals are able to charge for that. And I personally think that that's a problem, that we've designed a system where people sometimes have to pay for that. I will say that there are ways to access sometimes records in hospital or via labs nowadays where you can just sign up and go onto a portal. It's not usual that you can do that for a family practice, unfortunately, and we need to move further into that direction. So I guess those are some of the rights that I think that patients have, but I wonder if you have any specific questions, Leslie, that I haven't addressed.
Well, I think it varies by province. There's challenges all over the place, but it's just fundamentally the purpose of my question is just to make sure that people understand that they do have rights. It's okay to ask. It's okay because many people who grew up with sort of the model, my parents included, are the physician, just leave that alone, but if we are moving towards a wellness model, ideally, in the end, it's about empowering
Yes.
yourself to understand. And I know that's very central to the philosophy of yourself and the team. So maybe you can talk a little bit about what it means to be empowered as a patient.
Yeah, that's such a good question, Leslie. We heard over and over again from our participants in OurCare that they really appreciated being part of the process, partly because it was an opportunity for them to learn so much about the healthcare system. And that healthcare system was kind of like a black box before they entered OurCare. And then they had all these questions and the questions were answered. And, every report that the patients wrote, they put recommendations in that says, we want other people to have the same education. And so there were a lot of recommendations that related to education and empowerment. So education about, what is the primary care system and the role related to that, but also how to navigate the system. I mean, ultimately, I think empowerment is enabling people with the right information to be able to take care of themselves. That means taking care of themselves in the context of the setting that they're in, but then also being able to navigate the system. But then, of course, not just having the information, but having then the means to be able to care for themselves as well. So another thing that we heard within the OurCare project was, that we need to have, for example, removal of financial barriers. And that health is more than just doctors and hospitals, that health also encompasses medications and eye care and dental care and mental health care, all these things that aren't necessarily covered. And so that, ideally empowerment would enable people to be able to achieve their full well-being. And so that's actually taking things a step further, and not something I think we're going to be able to achieve right away, but something that I hope that we could have in a vision forward. I think the last aspect that I want to get at that relates both to your rights question and empowerment question is this idea also of ensuring we're meeting the broad spectrum of needs. And so as an example, I think there are many people in society and maybe on the call who have different physical abilities and may have physical disabilities. And there are now rights that people with disability have in general related to accommodation. And those rights, I'm not familiar with all of them, but there are actually, laws that have been passed around accommodation. And if you feel like you're in a healthcare setting and they haven't accommodated your disability, I think that would be an example of when you could contact the ombudsperson or the college to say, I have this disability and I wasn't able to access this care. I think that in general with empowerment, we have to think about people's full spectrum of needs and the barriers from an equity lens as well. So I don't unfortunately think that we have any legislation that gives people the right to access care in a language other than English and French, but it's something that, you know, if we really want empowerment, we need to be able to deliver care to people who don't also speak English and French. And then one thing we've heard from our OurCare participants too is that, you know, primary care needs to meet all the needs. And so, you know, it can't be that a family doctor should be able to say, oh, I don't do addictions, it's out of my scope, you know, or I can't do gender affirming care, it's out of my scope. We should be, it's reasonable that a single family doctor may not have all those skills, but we should be setting people up in teams so that people are able to refer to a colleague or support patients to get the care that they need. And so if you know, I worry that sometimes people are not able to get the care they need even from their own primary care practice, and that becomes a very tricky situation. Sometimes the doctor is literally doing their best, they're trying, but they're not sure where to how to support you given the needs and their own qualifications or expertise or comfort. And so I think that's an issue that we also need to figure out how to address.
I think that leads to my next question. I mean, we've talked a lot about the primary care system in this country being the front door or the gateway to the rest of the healthcare system for the most part, not completely, but for a significant portion of it. And sometimes, you know, people probably wonder, why is the system gated this way? It's different in other countries. They have greater access to specialists, for example, where I need a referral. And what happens if somebody doesn't have a family doctor and their health is worsening and they really need that hip replacement or cardiac care or diabetes management from a medication perspective, and they need to see a specialist, but they don't have a family practitioner? What is the solution? And maybe we can't do that in 2 or 3 minutes, but what can be done about those people who are facing challenges, those 6+ million people who are in that situation?
It's such a terrible situation that people don't have access to care. I do want to say, and I think after the show notes, Leslie, you're going to share a link that we have from our website. So if people want to go to our website, ourcare.ca, you'll see kind of the work that we've done. But as part of that, we have a web page that we put together called Find a Family Doctor, where we have actually amalgamated all of the resources that are out there officially to support people to find family doctors. An important caveat is that, you know, many of these are centralized waiting lists, for example, where, you know, you register your name and the government is supposed to match you with a family doctor eventually, but sometimes that eventually can be several years. I've had patients say to me that, you know, they've moved to Northern Ontario and been told it'll be 10 years before they get a family doctor. So just to acknowledge that these systems are not always working, but we've listed at least all of the systems that are official in all of the provinces and territories. But the other thing that we list is something, you know, our portals or websites or phone numbers where in each province, you can usually connect with a nurse, a navigator, who can support you to actually connect with other parts of the healthcare system as needed. And so in many provinces or territories, you dial 811, and that's the number that then puts you in touch with a service that helps to connect you to other parts, to meet your healthcare needs. So as an example, some of the things they can do. So I know in Ontario, for example, you could speak to a nurse who could, for example, ensure that you are able to, you know, access mammography screening for breast cancer, or that you could get a kit to get screened for colorectal cancer, even without having a family doctor. And so that's one way in which people can try and get the care that they need, even when they don't have a family doctor. But all this to say is I completely acknowledge it's not sufficient, and our system is designed to have a family doctor so that you can, for many reasons, but one of the things that family doctors do is help you to navigate other parts of the system. So why is it designed that way? I mean, that is the core of what you asked, Leslie, and I'd say it is, you know, partly designed that way because we know that it is actually in general more efficient and cost effective if we have a single entry point, family medicine, where the family doctor who has generalist expertise can help you together figure out what is the next step that you need. And if we didn't have that, we would have, I think, a lot of chaos because people would often think that they need something when actually they don't. I need to see a dermatologist, I need an MRI, I need an X-ray, and actually the evidence would say, actually, you would be better off without that. That would be unnecessary, could even lead to harm, certainly unnecessary cost. And so family doctors have the expertise to help to manage the things that they can manage and then help you to figure out, okay, what needs further expertise. And all of the high functioning healthcare systems out there have that kind of setup. But of course, it rests on everyone being able to have access to primary care.
Absolutely. I mean, I think you raise an interesting point around access, people's knowledge of the system itself. The navigation services are only as good as the government's ability to promote them and people to understand where to get them. It's a little bit about why we introduced a couple of services here at MedicAlert, something called Health Hub, which is a portal where people can literally go in and do similar kinds of things. So I'd love to see us work together to be able to enhance our knowledge in that arena. And then our Health Navigator product, which is actually exactly as you discussed, the nurse navigators who are there to help and support people. And in our case, if it's even nutrition counseling as a part of that service, then they stay with that navigator for the life of that, and that navigator becomes coach, helping people to maintain their health and nutrition as they may be navigating something new like diabetes, for example. So every little bit right now helps. And my next question really goes to an issue that we will continue to face. We see it fundamentally in our Safe and Found program and the dementia population, which is a population in this country that is, to use a term, hockey sticking, quite frankly. It will double, almost double by the time we get to 2030, and by 2050, there will be close to 2 million people in this country who have dementia. That's challenging because we don't have the system, maybe from a care perspective we may, but from a support system for caregivers. It becomes really, really challenging to manage those sorts of things. So as our population begins to age, and we see all of these things colliding, is it going to get worse before it gets better? Or do you see something positive on the horizon?
I'm always a hopeful person.
We're glad, very glad.
And, I like to take an optimistic view. Even with that optimistic view, though, I do think that we are in for a tough few years. And I do think that we can make things better if we make the right decisions right now, but we do need our governments to act now. Are there things that we can do now that are going to help some people in a year or two? Absolutely. Like we see governments announcing things like new funding for team-based care. That kind of funding would allow more people to get access to primary care, so it has an immediate effect. We've seen some decisions across the country to frankly, paid family doctors differently and more, and that's going to have an effect. We see it having an effect already in places like BC with fewer people choosing to leave family practice. So that's helping to stabilize the workforce. Now, those are examples, and we need more of that, and we need not just those solutions. Like there's sort of a multi-pronged thing that we need to have. And I think what we need most of all is to actually work towards the goal of 100% of people having primary care and design around that goal. What I say is that if we try to go from like 75 to 80 or 80 to 85, we'll not get to where we need to go, because incremental improvement will mean we can just do the same things and just invest a little bit more money without really bold change. But in order for us to get to 100%, we really have to rethink how it is that we currently structure the healthcare system, particularly primary care. And it'll force us to innovate in ways to be able to then get to the goal that we really know to achieve. So yes, I think we're in for a hard few years, but I don't think it's all bleak if we can convince governments to make the right investments now.
So I think what you're beginning to lead towards is my next question, which is you started to hint at some of the solutions that need to happen today in order to be able to make that long-term outlook more positive. And this is what you and the team at OurCare call the OurCare standard. So let's talk a little bit about this. And because of my technical difficulties, I know you wanted to show a slide, and I don't have it available right now because I was rushing to do this, but I'm not sure if you have it handy to share. If not, we'll definitely share it with the people on the call afterwards. But I'm curious about what that standard is and how you arrived at that standard.
Yeah, so the OurCare standard is that every person in Canada should, actually, sorry, I should say the OurCare standard are 6 simple statements that summarize what every person in Canada should expect from the primary care system. And we've really, we pulled these together from our many consultations across the country. So over 16 months, we heard from more than 10,000 people across the country. I should say that, some of that was through a written survey, but a lot of it was actually through dialogues. And when we had dialogues with people, they came from a wide variety of backgrounds, of geography. And what was really remarkable was the degree of consensus. And so, there was a lot that people agreed on, and most fundamentally, they agreed that everybody deserves access to primary care and should have it regardless of their background, their experience, their life circumstance. And so we distilled all of, the essential elements of what we heard into these 6 statements. And so the statements, basically involve, first, everybody should have access to primary care, a clinician who's supported by a team, and it should be publicly covered. The second statement is about the care being timely and ongoing. The third one is that we need a wellness-oriented system. So primary care should be connected to social and community services to address social determinants of health to support overall well-being. The fourth is that everybody should have access to their own health record. And it should be available online and be able to be shared with clinicians and caregivers. The fifth is that everybody, that people should be getting culturally safe care that meets their needs from a workforce that represents the diversity of the population it serves. And so this really gets at this idea that we should have care that's free of racism and discrimination. Unfortunately, we've heard a lot of instances for that it should be accessible to, people regardless of language or accessibility, and that the full range of services should be there. And then the last is that primary care should be accountable to the communities it serves. And that accountability takes many different forms. It includes this idea of transparency so that we, know what the primary care system, how the primary care system is performing, the investments being put in and what we're getting in return for those investments, how people should be navigating the system, that we should have patients involved, at every level in terms of governance and decision-making, whether that be the clinic or at a provincial or national level. And that we should, government should be accountable to funding primary care at a level necessary for to meet the community needs. So those are the 6 elements of the standard. And if you go to our website, ourcare.ca, you'll see them laid out. And yeah, I think that's probably easier than me sharing my screen right now.
That's okay, but all of those standards that you've just shared with us were woven through the last hour of our conversation very, very clearly. And it is maybe, I want to say it's remarkable, but having been in healthcare as long as I've been in healthcare, it's not surprising to me that you found a remarkable consistency across the population that you spoke with and surveyed, that these are really very basic things at their core. How we achieve them is the complex part, obviously, because we have 13 healthcare systems in this country and no 2 systems are alike. But Nevertheless, the fact that that is consistent across the country is encouraging, because it gives legislators and those who have the control over how things roll in our environment something to hang on to that is substantive, that is actionable, and can be cohesive. So when we have provincial travel or change for people, that their experience in one province is not necessarily different than their experience in another province. And those are the kinds of things that I hope will happen in my lifetime. And I'm sure others on the call will feel the same way. We've got just a little bit of time left, and so I want to ask you one thing that connects to what we do here at MedicAlert, but I want to get a little bit of context first. So back when we were founded in 1961 here in Canada, MedicAlert was really about information sharing between physicians. There was no 911 system in Canada in 1961. Back then, paramedics were ambulance drivers, and maybe many people still call them ambulance drivers, even though they're clinical first responders and have a lot of training. Emergency medicine wasn't even a discipline at that time, and family doctors were the people who staffed emergency rooms on a part-time basis. So times have changed a lot, but MedicAlert is still here to support, whether it's through first response or in the emergency room, and perhaps even with primary care in some way. So is there a role that you could see MedicAlert playing in the context of this very significant and timely topic that we're speaking about today?
Well, what I like about what we're doing already, Leslie, is that we're starting to, already address the issue of patient and public engagement, education, and empowerment, just through even having a session like this, Health Hour Live. And I do think that's an important role that MedicAlert can play, supporting people to understand, as you said, what is the healthcare system all about? What are their rights? How can they navigate it? How can they find a family doctor? And I know that you already do some of that, and it would be, would love for you guys, for example, you can link to our Find a Family Doctor page and
Absolutely.
So grow that work even further. And I know we're also planning to try and raise people's IQ, healthcare, primary care IQ, so that they know, better how to navigate the system, why it is that we're in the crisis. And then I guess the second point is, okay, take all that education, empowerment, and knowledge and actually translate that to advocacy to actually get better results, because too many people are without care right now. And so, I think that's a role, again, that MedicAlert can support patients with. Again, I would say that on our website at ourcare.ca, if you go to the landing page, we have actually a little quiz there that allows you to say, okay, how does your care measure up to what the OurCare standard says it should be? You can actually see, how your province is faring on a number of things. But then importantly, there's actually a templated letter that you can fill out to your elected representative. So we take all the work out of doing that. You just have to put your name and email and postal code, and it auto-generates a letter to your elected representative, and you can choose to send that letter. And what I would love to see is a swell of letters to our elected representatives, drawing attention not just to the primary care crisis, but to these patient-led solutions. And then I think another area where MedicAlert is a leader is being able to kind of pull together people's health records. And so is there a way that you can continue to advocate for everybody to have access to their full health record, but also maybe even support demonstrating the power of how that looks and how you've been able to support that to happen for the people that you support?
Well, thank you, Tara. That's absolutely something we firmly believe in. Our subscribers and members have full access. It is their record. They're the ones who are responsible for inputting the information that helps in an emergency response situation. And of course, we want that to be active and engaged. Our first responder partners need that in order to be able to do their jobs. And we often like to think of ourselves as a bridge between the community in whatever form that looks like and the emergency room door. We'd rather make sure that we can help maintain individuals' health in the community than to get them to the emergency room door. But when that need arises, we're there as that bridge. And that's advocacy with respect to the kind of work that we do. We fill a gap, a necessary gap in the healthcare system. And we've been doing that for 60 years. So we're going to add our own letter, I think, to this from the advocacy perspective, to say this is as equally as an important part, but connecting parts of the system together that may not necessarily be connected right now. And that continues to ensure that there is access to care, no matter what form it takes. So Tara, I'd like to thank you very much for being my guest today. I have thoroughly enjoyed this conversation. I'm sure our members on the phone have enjoyed this as well. And thank you very much for enlightening us on something so important in terms of primary care and the real impact it has on people in Canada, and the importance that will continue to grow over time. And we're behind you in terms of the investment that's required. Thank you again for joining me today.
Thanks for having me, and thanks for drawing attention to primary care and the work we did on OurCare. So urge all of your listeners to go to ourcare.ca, and yeah, obviously also love any feedback you have for us in terms of what we can do to help move things forward further.
Perfect. So that's Health Hour Live, everyone. Thank you for joining us today, and stay tuned for more things coming in the future. Have a great day.